Alexander already explained a little bit that maybe logically I should have started with a part that is more was done for you, more meaning for your needs as sales representatives. But we decided to invert, and we start with the lecture that is just the lecture that I would have done for the expos. And this maybe makes a bit less sense logically, because a lot of the concepts are given in the first part that I would have given to you, but we decided to do this one when I'm still fresh, relatively fresh, and so my voice is still at the best since we have to film it. So this first part I will speak like I would have spoken on the expos stage. So I will address to you like if you were also together Kiefer orthopeda, and I'm pretty sure that a lot of you know more about Kiefer orthopedy than some of my colleagues, but still it could be a bit strange when I talk to you about when you treat this patient and so on. It's because this was meant to be for expos. Okay? I apologize if for you some parts maybe will be not so interesting, but I'm pretty sure that for you it's interesting always to get to know what is our daily life and what are the needs of your customers. Okay? So the presentation is Vertical Control Biomechanics. I am Stefano Troiani, and today I will talk to you and I will explain to you how to go from here to here. So basically how to control bite opening and vertical dimension during fixed orthodontic appliance treatment. The first question you could ask me is, why do we want to do it? Only because it looks nice on your final picture, a good intercuspidation? What are the reasons why we want to control the amount of bite opening during treatment? There are different reasons. The reason that we want to avoid posterior interferences is that we want to avoid, for example, hard anterior contacts. If when our patient close their mouth, they hit first with the molars, they will try to find a way to achieve a bite. And there is not a control, they will tend to hit the front teeth very hard, which can give abrasions or anterior crowding. Then other problems, they can have condylar distraction, and another effect of posterior interferences is that doesn't allow to have a proper amount of overbite. The condylar distraction happens because when the patient close, if hits first on the molars, to achieve contact on a maximum amount of teeth possible, the condyle will tend to get distracted. This is a problem, well, according to Jeffrey Okeson, for example, the etiology of temporomandibular problems is a combination of three factors: condylar instability, overloading, and lack of adaptation. This is condylar instability. So it's one risk factor for development on temporomandibular joint problems. Lack of stability can come from lack of adequate overbite, because ideal way, normally there are at least 2 contact points between the lower incisor and the upper incisor on each tooth. The upper central incisor, they have 3 contact points so that the 2 lower central incisors can have 2. This is needed in order to have stability, because in this way the anterior teeth, they support each other, upper and lower. What is the problem with this? In order to have all these contacts, especially the 2 central contacts, here and here, you need to go up next to the level of the lingual cingulum of the central incisor. And therefore, you need to have an overbite of at least 3 to 4 millimeters. Having an overbite of 1-2 millimeters is simply too little and will lead to lack of stability over time. Is this confirmed in literature? You can find a lot of studies that tells you that there is a relationship between problems with function and temporomandibular disorders and various kind of symptoms. But if I've got to be honest with you, I could also put you a slide with as many studies that tells you that there is no relation. What is the truth? This is one point that is not very clear according to literature in our field. So we have to rely upon what is also our clinical experience. Now you could tell me, okay, my clinical experience, my personal opinion is that I don't believe there is a relationship between posterior interferences, posterior precontacts, and temporomandibular joint problems. But then you still have another problem. Did it happen to you, and I'm pretty sure it happened to any of you, if you don't want to lie to me, that during treatment you have a patient that doesn't look bad, it looks very easy case. You put brackets on, you put wires, and then all of a sudden you have an open bite. Why does this happen? This happens because if the patient has got a distracted position of the condyle due to the fact that there is a posterior interferences, will come to you with a bite that is closed, it's normal. But then, as soon as you start to put archwares in, the patient will lose the proprioception, meaning that the archwires will work like if they were a splint. And the condyle will tend to go back in its most anterosuperior position, so the most stable position inside the fossa. And this will mean that will happen the opposite movement of the one that we saw before, and you will get bite opening. So the patient that look to you a very easy class 1 crowding patient, you start to align and all of a sudden you've got a class 2 open bite, maybe even surgical patient. And it's not very nice when it's a surprise for you and for the patient, because you know, if you say something before is science, if you say that afterwards is an excuse. So it's very good to try to foresee this. So this part is why do we care? Why do we want to take care of bite opening during fixed appliance treatment? The next question is how can we do that? Which tools we have to achieve this? If I ask you this, most likely you would ask me, or you would answer me, well, we can use elastics. We can use up and down elastics and we can close the bite. Can we do that? This is one patient one of my patients that had this kind of bite opening during treatment, and then I decided to use elastics. So I use a little bit of professional tricks, cutting the archwire, using vertical elastics, controlling the torque of the upper molars, and the bite gets closed, you can see. And if I stopped here, I could say, well done, but is the whole story. This is the end of treatment. You can say it's not perfect, but it's acceptable. But is this the end? What if I show you this and you start to see something coming up? What if I show you this and you can see that there is a relapse? Why there is a relapse? Because anytime you use vertical elastics, you compound two different effects. You've got an orthodontic relapse, meaning that the teeth that you tend to extrude with elastics will tend to reintrude, and then you've got condylar relapse, because when you use vertical elastics, you apply a vertical force, and if you have a posterior fulcrum, you will tend to distract the condyle that will tend then to go back to its position. So you will have relapse coming from two different sources, and this is why you should not do this. This is just to convince you. But so, if this is not the way, if vertical elastics is not the answer, what is the answer? The answer is here. The answer is that you have to take care of posterior precontacts, of posterior interferences, that are mostly located at the level of the second molars. And one of the tricks to solve this is that you should not take impression, so you don't know that this exists, so you don't need to solve it. But once that you start to look for it, you will see that this is a very recurring problem in your patients. One thing that may surprise you is that this is not so normal to look at. If you look at what American board did, American board analyzed a lot of the cases presented to them, and found out that the vast majority of mistakes that were present in these cases, and these cases are the best cases presented by American colleagues, were at the level of second molars. This is because we don't look at them. And if you start to look at them, you will see a lot of problems and you may be able to solve them. So which are these problems? We start with the lower molars. In the lower molars, the typical problem is that you may have over-erupted lower second molars. Normally they are over-erupted because there is a delay in eruption of the upper second molars, and so in a patient that has got, for example, a distal occlusion, you will have the lower second molars will be free to over-erupt, so they will be above the occlusal plane of the other teeth of the lower arch. You have different ways to address this problem: free anchorage, bite blocks, mini screws, or use light forces. Before going into that, I have to scare you a little bit and show you this. This is one of the most important articles written in the history of orthodontics. It was written in 1974 by Dr. Barston and Koenig. The problem is that Dr. Koenig was an engineer, so it's written in engineer language, which is basically not understandable for normal human beings. But if you really decide to spend 2 or 3 months of your life in reading this article and trying to see what it says, you will see that it actually says things that makes pretty much sense. It says that when you are in this situation, and when you've got a vertical malalignment of 2 teeth, and you want to achieve this, you would like to intrude the tooth that is more extruded, and you would like to extrude the tooth that is more intruded. You would like to level them. And how do you think you achieve this? Well, what you have here is what they call a geometry 1, which means that if you insert a wire, if you put a wire through the slots of the 2 brackets, you will tend to have 2 angles that are equal and on the same side. This will give you an intrusive force and an extrusive force. The problem is that this system here, from a physical point of view, is not in equilibrium, because you've got an intrusive force and an extrusive force. These 2 forces together is what is called a couple of forces. A couple of forces gives something that is called a moment. And a moment needs to be counteracted by equal and opposite moments, because the total amount of force and moments in a system must be 0. It's the 3rd principle of Newton. So what you have in reality, you don't have only these 2 forces, but you have 2 moments also acting on these teeth. Now you can tell me, this is all jolly good, but why do we care about this? You do care, because if you decide to insert a wire in these 2 teeth, you will not get what you may think, that is an intrusion of the more extruded tooth and an extrusion of the more intruded tooth. You will get something else. You will get this kind of movement, because it will be a combined movement that will be expressing not only a vertical force, but also a moment, and a moment express a rotation. This is interesting for you, because if you have such a situation that is an over-erupted second molar, if you just insert an arch wire here, what will happen is that if you get your 2 elements, you will tend to get an extrusive force on the first molar, which will be expressed very much, because extrusive force, they immediately work. An intrusive force on the second molar, which will work much less, because intrusive force take longer to express than extrusive force. But then you will have also 2 moments for which you will tend to get this. And you will have a pre-contact on the distal cusp of the lower second molar. So, in a situation like this, if your patient just get an arch wire inserted, you will get bite opening. In some cases, this can be beneficial if you've got a patient with a deep bite, but in many cases, you don't want this to happen. So, different ways to solve it. First way, free anchorage. For this case, I will show you the case First way, free anchorage. For this case, I will show you the case of Lena. When you look at Lena, she's a nice Danish girl, but she isn't perfect. When you look at her, especially three-quarter, you can start to notice she's got a very slight lip incompetence. You can see that more in detail. You can see that there is not really a good definition. There is a bit of strain of the mentalis muscle when she's got to close the lips together. Which means that in a patient like this, that has got also a short, rather short ramus height, so a general pattern of vertical growth, you want definitely to avoid any kind of opening, bite opening mechanics. Because if you've got a patient that has got already to fight to close her lips, and you put in a mechanic that is going to open the bite and therefore to separate even more the mandible from the maxilla, you will go into worsen the lip closure and to worsen her facial appearance, therefore. So, what is one possible solution? Since the patient has got also quite a relevant amount of crowding, it was decided to perform extractions. When you are going to extract, one thing that you can do, you can use the teeth that you're going to extract to level the second molar before extraction. Because anyway, what happened to this tooth and this tooth, you don't care, because they will be extracted. So this is the concept of free anchorage. When you've got teeth that are going to be extracted, you can use them before extraction to do other movements, because they are free anchorage. You get something for free for once in life. So this was done, and after a period, it's of course a minor movement. You can see the difference that this is an intrusive moment, and we don't care what happened as a reciprocal effect to the premolar, because the premolar is going to be extracted. When you do this, you have to take care that in the upper arch, you have, as you can see, a transpalatal bar with segments that are going to prevent the upper second molars from erupting. Because if you are intruding the lower second molar and you don't do anything about the upper second molar, you risk that they will follow, so they will extrude. After this, it becomes a normal treatment with normal extraction mechanics to come to a result, an occlusal result that is acceptable. What is interesting to see is what is the extraoral result. This is an extraction case, and what you can see is that the smile is rather wide, so there is not any black corridors like normally you can hear in extraction cases. But what is more interesting is to see what happens to the profile of the patient. Normally you hear that when you extract, you tend to flatten the profile of the patient, you tend to worsen the lips. But what do you think? When you look at this, especially the upper lip, because the lower lip of course has improved because we have been reducing the face height, but even the upper lip, this one is more flat than this one. The lip after extraction treatment has got a better anterior curl. This is due to the fact that when you are able to control the vertical and therefore try to induce an anterior rotation of the mandible, you will tend to reduce the anterior face height, and therefore the soft tissue will be like squeezed, for which you tend to increase the curl, which in a patient that had strain and therefore very flat lips, it's beneficial. We can also see that what happened in the superimposition made on the stable structure on the mandible. This is a control 2 years after the end of treatment, in which there is post-treatment stability, and this is due to the fact that there is an adequate, among other things, an adequate amount of overbite. The question is, of course, do we extract in all patients? And of course we don't. So what do we do if we don't have the luxus of free anchorage, if we don't have 2 premolars to spend? How can we level our over-erupted lower second molar? One of the possible ways is to use bite blocks. For this one, I will have the help of this patient, it's called Larena, that she came to my observation. And you can see also in Larena, especially when you look at this picture, you can see in the detail there is very much strain. This means that she's got to fight to close the lips, and this means that the upper and the lower lip, they lack of definition. Normally, you would like to have in the lower lip a curl like an S. Here is just flat. And also the upper lip is rather flat. So she's a patient that she's in a condition of strain. So you don't want to open up more her bite, because otherwise you will worsen this, and she will get even more strain during closure. When you look at the numbers of the cephalometry, you see that she's got, again, a rather short ramus. And a short ramus height is an indicator for possible posterior rotation of the mandible during growth. So, it's a patient that has got strain, is growing posteriorly, for which you want definitely to do anything you can to control the vertical. Unfortunately, when you look intraorally, you can also see that she's got a rather marked step between the second and the first molar. And this is due also to the fact that in one side on the upper arch, she had an extracted first molar, and therefore a second molar erupted in the place of the first molar. But during that time, the lower second molars, they had time to over-erupt and create a step. So how do you want to level this step? The answer is that in a patient like this, when you start, you can put fixed appliance in the upper, you can start to level the second molar and the first molar in the lower, just with a segment of rectangular night eye. But now you can ask me, okay, but this is exactly the situation that you showed us before. If we do this, we are into a geometry 1 or 2, for which we will tend to get this bad effect that we saw before. But this is when you have to use what is called a centric bite blocks. A centric bite blocks is a removable appliance that the patient wears full time, apart from when eating, is built in articulator, for which there is occlusion on the first molar and the premolar, so that the first molar is kept down, so there is no extrusion of the first molar and there is only intrusion of the second molar. This is not belonging to the patient that I show you, it's just a model to show you the appliance. It's important to build it in articulator if you don't want to use 1 hour on the chair to grind acrylic, which is not one of my favorite hobbies, so I would like to avoid it. After this goes on like a normal treatment. But you can observe that still there is a lack of intercuspidation. She didn't open up, but we are not satisfied about this. So what do you do now? You start to use vertical elastics, then you have to be afraid that the nun with the stick come to you. So you don't want to do that. There must be another solution. One of the things that you have to do in all patients, that I advise you, and if you want to take away something from this lecture, is take impressions of patients, of the teeth of patients during treatment, because you can see things that otherwise you couldn't see. All my patients get brackets placed with indirect bonding, so it's a very precise method, but despite that, look at the amount of bracket that had to be repositioned. When I saw this, I thought that my technician was drunk the day that she made the indirect bonding for the patient, but she wasn't. It's rather normal to have to reposition so many brackets, because some brackets you simply cannot place correct from the start due to the fact that, for example, premolars can be under-erupted. So you've got to make a repositioning, and the bite improves a lot, but still we have a problem. For example, one of the problems that you have often is here, that you can see you still have an overbite and an increased overjet, but you cannot really close it because there is an interference of the brackets on the lower incisor with the lingual surface of the upper incisor. This problem is a problem that happens if you try to achieve a good amount of overbite. If you close your patient with 0 mm of overbite, you will never have this, but you will also have a lot of instability. If you do this, you will have this problem if you use self-ligating brackets. With non-self-ligating brackets, we didn't have this problem. With self-ligating brackets, we are having this problem because they are thicker. And this is why we are shifting now to to use mini brackets, mini self-ligating brackets, whose one of the bigger advantages they have is that in the area of the lower incisor they are much less thick, so you don't get interferences with the upper incisor. But this case is, of course, a bit old, and we used still the normal brackets, and so we had the problem. How to solve this? The easiest way is to place a retainer from 3 to 3 in the lower arch, remove the brackets on the incisor, and make the last phases of finishing without the brackets on the front in the lower. Here, this case is not finished to me yet. There is still a lack of intercuspidation here. And I think still that the patient is not ready for just finishing elastics. It's still too much. So we take another impression mounted in articulator, and we look if there are posterior interferences. And look at this. I'm going to introduce you this one, that is the pre-contact on the distovestibular cusp of the upper second molar. Please remember it, because you will see it very often. And if you start to take impression with articulator mounting on your patients, you will see it in the majority of your patients. I will explain to you why it is like this, and why would we have this so often. For now, just know that this is one of your problems of which maybe you are not aware. Once that this is taken care of, you can achieve a good occlusal result. What about the face of the patient? There was an improvement. This is before, and this is after treatment. Of course, a part of the improvement is that she learned how to use makeup, and that is not up to me. I don't teach that to my patients. But what about what I can work on that is not makeup is the lips. You can see that this was a non-extraction treatment, but despite that non-extraction treatment, you can see that before there was much less curl, this S definition of the lower lip, and therefore, even in a non-extraction treatment, you can improve lip competence by using vertical control. These are the superimposition on the stable structure that showed the effect of treatment. This is 2 years after the end of treatment, to show you that she stopped, unfortunately, using makeup again. But, of course, the extraoral appearance is still stable. What about intraorally? We still have a very stable result. And this is what is important to also check what happens after the end of treatment. The use of mini screws you can find in so many courses that is not particularly interesting for me to show you. I will show you later a patient in which I use mini screws to control the vertical in the lower. Another thing that you may want to know is in some patients you don't need to extract teeth. In some patients you don't need to use bite blocks. You just need to keep the force level very low. So you have to use light forces and be very careful in leveling. This is one of my patients. She is not on drugs, if you are asking yourself that she's too young. And this is how she looks like. She looks a bit better than the other patients, because you can see that she's got a little bit of strain in the mentalis muscle and the lips, but not so much as the patient before. However, still, also with her, we have a rather bad prognostic indication of the growth. She's a little bit a vertical grower. So we may think that she is going to develop even more vertical than what she is now. So we have to take care a little bit. But we can say it's a bit less severe case than the previous one. Intraorally, this is the situation. There is some crowding, especially in the lower there is marked crowding with impaction of one premolar and an incisor that is totally blocked out. It was decided to remove this incisor because this one is so much out of bone that even leveling it into arch would have a very bad prognosis. Leveling it into arch would have a very bad prognosis. But afterwards, this is the sequence, and you can see it's a very long sequence, and you can see that the bite is kept quite down. How this is done? In a patient that has got a tendency for vertical growth, and you want to try to keep the bite down, but you don't need very complicated tools like bite blocks or extra or free anchorage, you can do this just by leveling very slow. Personally, I use 3 months at 0.12 night high, 3 months at 0.14 initial LOI, 3 months at 0.18 initial LOI before proceeding to rectangular arch wires like bioactive. You also want to avoid in this patient to go in full size steel wires, because any kind of lack of precision in placement of bands, tubes or brackets, you risk to pay that very hard, because in a patient that is posterior grower, if you go in full size steel and you get pre-contacts, the bite open up and can get very difficult to control. So whereas normally I finish my patient in 1925, 2025 steel, in this patient sometimes I go only up to a full size rectangular wire, bioactive, for example, or shifting steel in one arch, having bioactive in the other arch. So no full-size steel in both arches at the same time. Of course, there is also same procedure as the other patient, some repositioning that allow to close the bite further and to come to a final result. Interesting to see that the look stays the same. But what is interesting to see is the profile, that despite vertical growth, the profile, I would say, improved during growth. And you can see that there is a very nice curl. Of course, there is also an aspect that is natural growth that occurred that it was not unfavorable, but all we can say is that we have to try to not worsen what nature offers us. These are the superimposition, and this is the final occlusal result. Of course, there are only 3 incisors, therefore the midline is centered on the lower central incisors, but there is otherwise an acceptable level of occlusion. This is, again, compared with the articulator mounting, so that there is also, you can see that there is no discrepancy between centric relation and centric occlusion. This was about controlling the lower molars. What about the upper molars? Which are the most common problems that we have there? The most common problem by far is that we can have hanging palatal cusp of the upper second molar. Why do we have this? We have this is due to the way that upper second molar erupt, and this is due also to the fact that very often they are the expression of dental-alveolar compensation to a transversal discrepancy. So basically, whenever you have a maxilla that is constricted with respect to the lower arch, the upper molars will tend to flare out to try to compensate this. Being flared out will give hanging palatal cusps. How can we address this problem? A first way is to use, of course, transpalatal arches. And for this one, we use the example of Elizabeth. Elizabeth, she's a girl. She comes to my practice, and she doesn't have major issue from an extraoral point of view. And intraorally, also, she doesn't have so big problems. She's got some lack of space, some flaring, but you can see she's got a rather neutral occlusion, no big problems. So this is an easy case. We just have to control that there is space enough for all teeth, and you can see and look at the amount of overbite. Right now, she's got a rather deep bite. This is a case in which we are not doing much. We are just placing brackets, wires, and waiting. But what happens then? It happens then, all of a sudden, our bite starts to get more and more open. We get it here. We start to have a total lack of intercuspidation on the posterior aspects. We get it here. can you see that now the two arches basically are not touching anymore? Why? Because if you look at the second molars, they are very much flared out. How can you see this? Well, you have to take, again, as I said before, intermediate impression. If you look at it in the mouth, it's very difficult to notice. Once that you see this, how can you correct this? As I said before, one way is to use transpalatal arches, activate it for torque and for the slight contraction of the second molar, with which we are trying to intrude the palatal cusps, so to close the bite. And this has got a very good effect because you can see immediately the bite closed down. If you go back, you notice before inserting there was a lot of space between the upper and the lower arch, and just after it tends to close down. You have to keep doing this for several months. It takes long. But then you can get to a point in which you get an acceptable occlusion, and then you can finish your case with an acceptable extraoral result. I didn't change the gender of my patient during treatment. I cannot do that with treatment, with fixed appliance. The extraoral appearance stayed rather the same. She had normal growth. What is important to see is that it was possible to achieve a very good intercuspidation at the end of treatment by taking care of posterior precontacts. Sometimes we cannot just do it, because sometimes our problem can be the morphology of the second molar. What happens if we have an extreme malformation of the second molars in the upper? What happens if we have a malposition that is so marked that we cannot correct it? Well, in that case, you have two ways to do. You can make coronoplasty, or if you want to be more honest, you can say you have to take a burr and try to slide a little bit the tooth, or you have to extract some time. You have to extract the second molar. This is Louise. Louise, she was one of my terror patients because she's a girl, 16, good looking, from a good family, extremely spoiled. So she has got all the points that make of her a bad girlfriend and a bad patient. For me, it was a bad patient. So this is her appearance. You can start to see, by looking at the extraoral picture, that she's got a certain degree of maxillary hypoplasia. When you look at her, you can see she's got some flatness of the paranasal area. She's got a rather flat upper lip, flat lower lip. She's a class 3 open bite patient. You can also see that looking at her X-rays, and you can see it even more looking at her intraoral picture. This is the way she bites. I apologize a little bit for the quality of the picture, but this is a very old case. So at the time, this is what I got from my photographic skills, that they didn't prove much in the MIWAL, but you can see the patient has got open bite. Occlusally, she's more or less neutral, but that is typical of class 3. When a class 3 is also open, the fact that the mandible is posteriorly rotated will give you a neutral occlusion, even if though it's a class 3 skeletal. There is posterior crossbite because the maxilla is deficient, and very severe crowding, both upper and lower arch. So, such a patient for me is best served with a combined treatment with orthodontics and surgery. However, this patient I treated this patient in Denmark. In Denmark, I cannot decide if the patient will get surgery. It's a committee of surgeons that has got to decide if the patient has got the right to get a free operation. So I send the patient to this committee. This committee say, well, maybe, but we would like you to try first without. And I said, thank you very much, that is beautiful, but I will have to do it because that's the way. A patient in Denmark, normally they cannot pay a private operation. There is no place in Denmark where private operations are done with relation to jaw surgery. So the most obvious solution here was start with extraction treatment, because of course a patient has got already this kind of open bite, class 3, you cannot avoid extractions here. So I extracted 4 premolars and I started to treat the patient. I started to close the space, but this is the kind of bite opening that I had. There is no hope to put these 2 arches together. Why was the situation? Well, if you look at that, the situation was due to the fact that, look at the second molars, they are over-erupted probably around 5 or 6 millimeters. Now, how can I control this? Many of you start to think mini screws. Unfortunately, there was a little contraindication. This case is before mini screws existed. So I couldn't use something that didn't exist, surprisingly enough. Then you can tell me, you can try with a transpalatal arch placed very low. You could do it, but this is a bit too much for that, and especially the patient wouldn't tolerate it in any way, because as I told you, she was not really the most cooperative that I ever had. Since the patient had the 3rd molars, I decided to extract the 2nd molars. And I know I had already extracted 4 premolars. So she had extracted 4 premolars and 2 upper molars. So after extraction, you can see here there is space. What was done was to include into the arch in the upper the 3rd molar as soon as they erupted. What happens when you do this? Well, of course, the 3rd molars will erupt very quick, but you will also get a little bit of intrusion of the posterior part of the upper arch. Basically, you will simulate in this way a Lefort 1 osteotomy with posterior impaction, which is what is used to close the bite surgically, or was used. And you can see by doing this, I start to achieve what looks like a more decent intercuspidation. These are the 3rd molars, the 2nd molars have been extracted, and the 3rd molars have been coming down in place. I referred her for extraction of this 3rd molar, and the surgeons told me, no, we don't think it should be extracted. So my relationship with surgeons in Denmark has not been very idyllic, in this case at least. This is the final result. Of course, it's not perfect. It's a compromise. However, considering the situation at the start, that was this one, all in all, I think is an acceptable result without surgery. But what about extraorally? Extraorally, this is the change for the patient. This is before and after. And what is interesting to see is, what about her profile? Do you think got worse by extracting 6 teeth? Well, this is before and this is after. She's of course still a class 3 patient. There is no doubt. But still, if you look at this and this, can you see the lower lip, for example? This one is very straight. Here, there is a bit more of a curl.